Hello, second part of hematology. We're gonna talk about anemia. So let's begin. First of all, let's write anemia. What's anemia? Where's my pen? Yeah. Anemia is a problem of not having enough healthy red blood cells, hemoglobin, or hematocrits, and so on. As we took from the first part, we know that hemoglobin and hematocrits, when they are elevated, they called polycythemia vera, and when they decrease, they called anemia, which is our topic for today. Clinical features of anemia is clear. Always we're gonna see fatigue, we're gonna see dyspnea, we're gonna see conjunctival pallor, we're gonna see tachycardia, which are non-specific symptoms, but in all cases of anemia we can see them. To check anemia, to identify anemia, first thing we're gonna check it, or we're gonna search for it in the CBCs are MCV, which is called mean corpuscular volume. It has also a range, a normals between, normal of it is between 80 to 100 femoliter. With MSCV, we can find severity of anemia. We can differentiate between types of anemias due to it. It will be divided to 3 cases of MCV. First of all, if MCV was smaller or less than 80 femoliter, which called microcytic another case which is in which MCV is between normal range, that's also possible, which called normocytic third case in which MCV is greater than 100 femoliters, which is called macrocytic We also search for reticulocytes which is immature or RBCs. Um, we're gonna search for count of it in the bone marrow to evaluate. Due to criteria, like there's a lot of criteria globally. Due to countries, criteria are changing due to the country protocol and so on. But there is general criteria which is from World Health Organization, WHO, criteria of anemia. Anemia. So to identify anemia due to the criteria of WHO, for men, hemoglobin must be less than 13 gram per deciliter. So the normal range is 130 to 160 or 13 to 16. For females, the criteria of WHO hemoglobin should be less than 12 gram per deciliter. The normal is 120 to 140, so 12 to 14. For pregnancy, case of pregnancy, hemoglobin should be less than 11 gram per deciliter or less than 110. In case of children, also they have special criteria. For children, due to the months or years or age, let me say, so 6 to 59 month child should have hemoglobin less than 11 grams. So that time we can say he or she is having anemia. Another age criteria, which is between 5 to 11 years at this time, they must have hemoglobin less than 11.5 per deciliter to be counted as people as anemic cases. Another criteria, due to age between 12 to 14 years old, hemoglobin here also should be less than 12.5 gram per deciliter. So here you have it. We can tell them that they're having anemia. So now I want to talk about types of anemia due to level of MCV, when it decreased, when it increased, or when it's in normal range. So as we know here, we have mentioned you have three types or three cases of MCV range when they are lower than normal range, lower than 80, when they are above than 100, and when they are normal range. So let's begin. First case, which will be today's only topic in the video, because I want to make separate videos for normocytic and macrocytic anemia also. So today we are having microcytic anemias. Here, level of MCV gonna be less than 80. Sorry, yeah, gonna be less than 80 fair liter. First type of anemia, which is the most common one, I want to talk about it. It is iron deficiency anemia. Anemia IDA, which is the most common microcytic anemia. Okay, first let you go for the causes. Etiology. First of all, menstrual bleeding. It's one of the most common causes, like we are having menorrhagia, we can say also GIT bleeding, which will be two types: upper GIT bleeding and lower GIT bleeding. Just upper GIT bleeding, also lower GIT bleeding. Upper GIT bleeding, we can see blood in vomits. So vomit with blood. In the lower GIT bleeding, we can see melanoma or dark stool. Okay, third cause, we can talk about it. It is like decrease absorption of iron. Decrease absorption of iron is one of the important causes. We are having two cases here too. We are having like atrophic gastritis. In case of atrophic gastritis, and in case of inflammatory bowel diseases, so IBD. Another cause, we go for it, which is increased demands. Which is in case of pregnancy. Of course, like one more important cause that I want to mention it at the end, which is less dietary intake of iron, which is most common in plant-based diet, like in vegan people. Because the iron they are taking it is non-hemic iron. Even they take it with tablets and supplements. It cannot be that enough for them, so they need to take twice. So let me now go to the pathology of it. Yes. So, in case of iron deficiency anemia, we're gonna see decrease in what bind of iron towards to protoporphyrin, which will lead to decrease production of hemoglobin. Iron normally when we take it, it will be absorbed in the intestine, so duodenum directly, especially duodenum, they will be absorbed in the duodenum. We are having, as we said, two types of iron. We are having hemi-iron. We are having vegan people's iron, which is non-hemi-iron. Let me talk about non-hemi-iron a little bit. It's not related to us, but for the vegan people. Okay. You can find it in plants as, I don't know, beans, spinach, and so. Which is the problem is that it's less efficient for absorption. And also it requires reduction from Fe plus 3 to Fe plus 3, which called ferric Fe plus 2, which called ferrous by special enzyme from duodenum, which calls duodenal cytochrome B, or this. Okay, that was the absorption. Now another step gonna be the transport of iron. So also two. Iron will be transported and it can be stored as ferritin within enterocytes, or release into circulations. Okay, then we are having utilization of iron. Which gonna be like that. Like transferring bound iron, will be transferred to the cells, and like of course through the transferrin receptors and so on. Then again for the storage, like I'm talking here about the ferritin. This one's released in the circulations. Also, you're having two main ways of it. It can be stored as ferritin again, and hemosiderin, which can be found in macrophages, or it can be functional use again. What we need is ferritin, which can be stored in the liver, in the spleen, in the bone marrow, spleen, and bone marrow. So that was the circulation of iron in our body, like the normal circulations. Okay, now that we talk about clinical features. Clinical features, as I said, it's same for each type of anemia. We can see fatigue, lethargy, pallor, like they are not specific, but I want to just write the specific one. Specific clinical features of iron deficiency anemia. We can see brittle nails. We can see cholynochia. which is specific for iron deficiency anemia. It is rarely seen in high common income countries, but it's specific for iron deficiency anemia, which is like a sponge like nails, you know. We can see hair loss, we can see dyspnea, cyanosis, we can see tachycardia, angina, and so on. The clinical features, as I said, is like almost all same, like no specific. We can see what was called, yeah, it was, let me write it with this pica, which is eating disorder, dysphagia, and so on. So now that we talk about the diagnosis, like method of diagnosis, what we're gonna use, what we can see, how we can identify it. Okay, let's write about the diagnosis. We can use, of course, first CBC. Here we can see low MCV, as I said, 0.8 or AT, we can say, less of iron serum, we can see decreased ferritin, we can see decreased hemoglobin. Here for the MCV is typical for iron deficiency anemia. But there are some cases, like exceptions also. Nothing is not 100% sure. There is cases with normocytic, in which MCV is normal. Okay, that was in MCV. Also, still we are in CBC. Sorry. We can see reticulocytes. They may be normal or low. We can check for MCH this time. Yeah, mean corpuscular hemoglobin, which can be also 2. It can be hypochromic. It can be normal. The hypochromic one, if we see it, so it's also typically for iron deficiency anemia. Another interesting point is that RTW, red cell width, like red cell distribution width opposite of those decreased or normal, it is increased, it's elevated. That is elevated. Okay, let me go for the treatments. I just separated with A, B, C, D. So A, for example, we are having case of abnormal uterine bleeding, menorrhagia, abnormal uterine bleeding. We can here apply hormonal therapy or OCPS, which is oral contraceptive pills. We can give tranexamic acid or gynecological surgery. So stop the bleeding if you have the case of abnormal uterine bleeding. Iron deficiency anemia will be healed itself. So the treatment in general is underlying the conditions. Okay, in case of, let me say, yeah, if you have GI pathology, gastrointestinal pathology, yeah. If there is like H. pylori case, give it therapy, treat it. If we are having GIT bleeding, for example, we can do polypectomy. We can also do treatment of GI malignancy. Like there is tumors, for example, like we are having colon cancer. So the treatment here is also underlying the disease condition. Another case, yeah, hookworm infection. Which is like it's a parasitic infection which typically causes iron deficiency anemia. Here we are giving anti-helminthics. So kill the bacteria, treat the infection, help iron deficiency anemia. Another case, in case of malnutrition and malabsorption. Malnutrition and malabsorption. Also, due to the list of substance, we're gonna treat it and like give the substance, for example. It's also treatment underlying the condition. So underlying the condition, like here we are having list of iron serum. We're gonna give 1 milligram per day, for example. Okay, let me go to section B of treatment of iron deficiency anemia, which is dietary modifications. Here we're gonna talk about dietary modifications. Of course, for iron deficiency anemia. We do it like first, of course, we're gonna give iron rich foods like especially the hemi-iron rich foods, which is from animal sources. Like fish, meat, red meat, and so on. We can apply, like we can give vitamin C or foods with vitamin C to say with vitamin C to help what? To help for increase absorption of iron in the body. Second one, it was no, third one. Like we should limit substances that reduce iron absorption. Like, for example, we can say tea, cereals, dairy products, some soy products, and so on. Another one, drugs or chemical substances that reduce iron absorption, which is to reduce calcium, antacids, proton pump inhibitors, family drugs like Zol family, for example, omeprazole. Okay, section C for the treatment, which in this case we are considering PRBCs, blood transfusion, cases of for example, in case of hemodynamically unstable patient with anemia. Another one. In case of severe anemia, in which hemoglobin is less or equal to 7 grams. This is also in some special case, like select patients with like hemoglobin is less or equal to 8 gram per deciliter. At that time also need to apply PRBCs, which is the blood transfusion. That's for people who are suffering with cardiac disease and orthopedic disease. Last section of the treatment. Now is monitoring things, so we always need to check the CBC in 3 phases. First of all, monthly, until we're gonna get like the normal range. Second, like every 3 months. Duration for a year. And then once after a year, like repeated. Okay, we are having now the complications of iron deficiency anemia, and we can also, okay, before the complications, which will write a criteria of suggested daily iron intake daily, which is again by WHO, I think. So daily iron take recommendation. We are having, as we write here, age for males, females, and so on. Age we are having equal or less than 6 months, or until age of 6 months. We are having 7 to 12 months, 1 to 3 years, 4 to 8 years, 9 to 13, 14 to 18, and 19 to 50, and we are having less or older than 51 years old. Okay, so here, first of all, younger or age of 6 months for male and female are same. We're gonna give 0.27 milligrams of iron daily. Another one, age of 7 to 12, we're gonna give both of them 11 milligrams daily. Then from age 1 to 3 years old, you're gonna give 7 milligrams. Then age 4 to 8 years old, we're gonna give 10. Age 9 to 13, we're gonna give 8 milligrams. In age of 14, 14 to 18, the needs for iron will be differentiated. For males, for example, we are giving 11 milligrams. For female, we are giving 15. In age 19 to 50, for males, we are giving 8 milligrams. For women, 18 milligrams. In case of pregnancy, 20, like non-pregnancy, sorry, we are giving 27 milligrams. In case of pregnancy, 9 milligrams when she's on breastfeed, and 8 milligrams when she's post menopause. And yes, 8 milligrams when she's older than 51 years old. Also here for male, the same 8 milligram for 19 to 50 years old, and 51 years old also till death. 8 milligrams daily is enough. Also, like, we should not forget American National Academy of Medicine. They are recommending vegan people to take more than the normal range of the iron twice, because the iron that they take, as we said, is non-hemic iron, which need more time, take more time to absorb to get the benefit from it to our body and life process. God help them. Complications of anemia at the end that we talk about. It's like it will cause heart failure, maybe increased infections, restless leg syndrome, which is a neurological disease, and in pregnancy it will elevate maternity or neonatal morbidity. It will be low breath weight, like low birth weight for the child. Preterm labor in children, it will cause developmental delay and low educational attainment. So now that we talk about thalassemia, in this case also MCV is decreased. So our next case is thalassemia. Must be top of this. Anyway, so what's thalassemia? Thalassemia are hereditary hemoglobin disorders characterized by mutation on alpha and beta globulins, which will result alpha or beta thalassemia due to the all criteria of thalassemia. Uh, let me make the criteria. First of all, let me say we are having alpha thalassemia, which is like change in the or mutation in the alpha globulins. It's hereditary, as we said. So alpha thalassemia. We are having 4 degrees of alpha thalassemia. Let me say 1, 2, 3, and 4. First of all, we are having first degree, which is like one gene effect, one gene defect. It's called like silent anemia. Here we can see like there is no symptoms, that's why it's called. With no symptoms. Second one, we are having second degree of alpha thalassemia, which in it 2 genes are defected. Here we can see mild anemia. It can also be called as alpha thalassemia trait. Third degree of the alpha thalassemia, this is when there are 3 genes are defected. Here it's called moderate anemia. It's called also hemoglobin H disease. Clinical features, we can see jaundice, anemia at birth, of course. We can see chronic hemolytic anemia. Another clinical feature is secondary hemochromatosis. Also, we can see hepatosplenomegaly. Hepatosplenomegaly. Okay. 4th degree, and there's 4 gene defected. Here we are having severe anemia. Also called hemoglobin Bart's disease. It's also like consists of for gamma chains. Okay, clinical features. You can see high drops, fetalis, intrauterine cysts. Yeah, that was for alpha type of thalassemia. Alpha thalassemia is also, let me say, you can see it in Africans, Americans, and Asian countries. Another type of thalassemia, we are having beta. Let it be another page. We are having now the beta one. Beta thalassemia. So don't forget, it's predominant in Mediterranean descents. We are having also 4 types of it. First of all, minora. Here is one gene, like one allele, not gene, allele defect. Signs will be no signs or mild anemia. Okay, another one. We are having intermediate, it is like 2 defective alleles. Or like, yeah, or inheritance of other variants. Clinical signs. We can see variable anemia. It may require transfusion during periods of stress. During periods of stress. During, for example, let's say surgery, infection, of course, pregnancy. Yes. Third type of it is majora. Okay. Here also 2 defective allele. We have clinical features. Gonna be severe hemolytic anemia, which requires frequent transfusion. Second one will be secondary hemochromatosis, hepatosplenomegaly, growth retardation, and yeah, another type of it, which is I saw just in this criteria. It's called sickle cell beta thalassemia. It is like a combination of one defective beta globin and one defective HBS allele. Features will be like sickle cell disease, just like sickle cell disease. That was about thalassemia, which also MCV decreased. And yeah, treatment for each thalassemia is only like best treatment, blood transfusion every 2 weeks. And that's thalassemia. And now let me talk about one more case of less MCV, which is our lovely anemia of chronic disease. Anemia of chronic disease, or anemia of chronic inflammation. As a short definition, like it's a multifactorial anemia. Diagnosis of this type of anemia require to have inflammation and chronic inflammation condition, such as like diseases of kidney, cancer, such as like rheumatoid arthritis, tuberculosis, ankylosing spondylitis, ulcerative colitis, and rheumatoid arthritis, as I said, and yeah, so on. For that, here we can see like MCV usually is low, but sometimes also norm. We can see reticulocytes are low. We can see iron transferrin are low, but the stupid thing here is that ferritin is normal or elevated. Why is elevated? Because of in the inflammations we are having macrophages in the body, so ferritin will be stored there. To diagnose, for the diagnose, it's like we need CBC, reticulocyte count, we need bone marrow examinations, we need iron studies, and here also RDW is normal, sorry, and hemoglobin is usually more than 8. Yeah, that's the way of diagnosis of it. So it's anemia with a chronic inflammation, like I said, rheumatoid arthritis, tuberculosis, acute spondylitis, and so on. For diagnosis, you can see low ACV, sometimes normal, low reticulocytes, low iron and transferrin, but ferritin in here is normal or it's high because of the macrophages. Normal redistribution width, and usually hemoglobin is more than 8. For the treatment, like it's also reserve underlying the disorder in some cases, like first of all underlying the disorder, in some cases we're gonna give erythropoietins. And that's it. So our last case for today, case of decreased MCV, we are having sideroblastic anemias. So sideroblastic anemia is like disease of a group of anemias characterized by presence of high iron levels, ferritin also high, and of course transferrin is high. Symptoms like any anemia, fatigability, lethargy, and so on. We have two types of sideroblastic anemia. First of all, let's just talk about the acquired one. You're having acquired and congenital. So the acquired one associated usually with what myeloblastic syndrome. But maybe caused also by medications. But maybe caused by medications or any substance. Like toxins, and of course will cause normocytic sometimes and macrocytic anemia. Except the myeloblastic syndrome, which is usual with it, we can say also like vitamin B6 deficiency, vitamin B6, which is also called pyridoxine. Or copper 2. Medications which causes plus here. Medications which cause, for example, we can say chloramphenicol, phenicol, isoniazide, tuberculosis, and so on. Toxins like ethanol or leads. That was for the acquired sideroblastic anemia. And another type of it, as we said, it is congenital. Congenital. Ding, ding. Congenital is caused by numerous X-linked or autosomal mutations, and it is usually microcytic, of course, and hypochromic anemia. But as always, exception, it can be also normocytic. So we have two types, as we said, congenital and acquired. Congenital, we have talked about it usually with myeloblastic syndrome, but it can be also with medication toxins, also they can cause it. Congenitals is usually numerous of X-linked or autosomal mutations, and it's usually microcytic, as we said, or antihypochromic, but it can be also normocytic. For the diagnosis of the patient with sideroblastic anemia, we can suspect microcytic anemia, as I said, from the CBC. We can say high red cells distribution width. Like, yeah, we are asking for CBC. We are asking for reticulocyte count. We will ask for bone marrow examinations, like maybe we are having like ring sideroblasts in the bone marrow examination. For the treatment, stop causative agent, like determining the agent is the treatment already, plus we will give vitamins like B6, redoxin, vitamin B6, or mineral supplements like copper, zinc, so on, and sometimes also recombinant erythropoietin. EPO. That was all for today, second part of the hematology classes. The next class will be about normocytic and macrocytic anemias in one video, and wish you a nice day.